Hello, thank you for joining me on this short survey of a number of terms and situations that might be important for those preparing for the pathology portion of the Gyn-Oncology boards. This was prompted by our local GYN fellows' request for such a topic and discussion, and I thought it might be valuable for some others, so I'm sharing with you now. We're going to focus on a number of terms and delve into some of the history behind some of those terms as well as we go along. Of course, this is not an all-inclusive review, but is designed to touch on a number of topics that may show up on your boards. So as we do this, I want to emphasize the importance of working effectively between the surgeon, gynecologist, oncologist, and the pathologist. And so understanding the terms that we're using and a little bit about their background can be oftentimes very helpful. So the first and perhaps a very fundamental term is the word Cirrus. This term refers to the most common type of epithelial tumors that occur in the GYN tract. But historically, it goes back to the beliefs that these tumors were derived from the so-called surface epithelium of the ovary, those that involved a serosal surface. However, more recently, we've come to recognize that these tumors are actually derived from fallopian tube type of epithelium, which is ciliated, as you see here, and that this site of origin allows a very rapid spread to the ovaries and to the peritoneum generally. Of course, these cancers can be both high or low grade, but in general, serous tumors tend to be to share the phenotype of being WT1 positive, PAX8 positive, and CK7 positive. This is, of course, in the ovary. In the uterus, the serous tumors may lose the WT1 positivity. And most of these tumors will also express some degree of hormonal marker as well. Now, they can come in a variety of categories and flavors, if you will, from benign to borderline, low-grade carcinoma, and even high-grade carcinoma. And this illustrates that in this image here, which you see a very different appearance here with this filigree pattern, papillary, delicate cytologic pattern with a very dense stroma, in comparison to a nearly solid tumor with a high degree of nuclear pleomorphism, mitotic activity, and an inflammatory diathesis in some of the lumens. And then looking again here, we see even a more benign appearing lesion here on the right, and a deceptively benign pattern here where you get lots of psammomatous calcifications and little small nests of tumor here in an infiltrating invasive low-grade serous carcinoma with a desmoplastic response, or could also be seen with a psammocarcinoma type of lesion. So the morphologic spectrum can be broad, and that makes their classification very critical and sometimes prone to either overcalling or undercalling. Now, as pathologists, we're concerned with the differentiation between benign and borderline, between borderline and low grade, and between high and low grade. And oftentimes these distinctions are based on morphology, but sometimes they're also based on immunohistochemistry or even molecular phenotypes such as low grade versus high grade, where the presence of a TP53 mutation is highly predictive of a high grade status. In contrast, the distinction between borderline and low grade tumors can be extraordinarily difficult, and largely depends upon the demonstration of invasive behavior, because even borderline ovarian tumors of serous type can have nodal metastases without them necessarily being called carcinoma. Now, another term that pops up in the serous category is the term micropapillary. And this is a descriptor for structures that have small cell groupings, usually 3 to 10 cells, maybe larger, but oftentimes without an identifiable central vessel. Papillae, as you'll recall, have a central vessel, an outer lining of epithelial cells, but micropapillary, you lose that demand or that requirement for the central vessel. Now, as we apply this to serous tumors, this is generally further refined to reflect papillae that are 5 times as long as they are wide. So you can see here, some of these are clearly much longer than they are wide, a very narrow filigree type of pattern. Another feature that's identified here is the so-called Medusa's head, taken from Greek mythology, where the Medusa had hair that was snake-like coming from all over her head. And that's really the appearance that you see here, where a central core has these very delicate, elongated papillary fronds extending out in all directions from all sides of the core. Now, in breast tumors, the meaning is somewhat different. It tends to connote an inverted luminal pattern that has a very highly aggressive and low cohesiveness, or early prone to metastasis type of appearance. Mucinous tumors, of course, are a big challenge pathologically and clinically. But essentially, any cells that produce mucin can be considered mucinous. But not all tumors that produce mucin are necessarily mucinous ovarian tumors. So with that distinction, we need to recognize that there are several important subtypes. First of all, the most frequently encountered is the enteric type of primary ovarian mucinous neoplasia, which has that moniker because it tends to have goblet cells and will oftentimes be CDX2 positive with some CD20 positive, CK20 positivity, and variable CK7 expression. Now, importantly, these primary ovarian tumors with this GI phenotype or enteric phenotype will lack the marker SATB2, which becomes an important distinguisher as you try to exclude the need to find a metastatic origin for these tumors. Endocervical tumors tend to be a little smaller and be CDX2 negative, but strongly CK7 positive, as well as having hormone positivity or variability along with PAX8 in those situations. Occasionally, these enteric types will also be PAX8 positive as well. Now, we've mentioned that the metastatic tumors can present in this way, but will usually be SATB2 positive. Of course, if you find a mucinous appendiceal neoplasm, that almost certainly means that whatever's in the ovary is metastatic. But more often, we're looking at the ovarian tumor and asking ourselves, where did this come from, or could this have come from someplace else? Now, there are 2 other types of mucinous neoplasia in the ovary. These are less frequent, but certainly not impossible. A number of endometrioid tumors can differentiate towards the mucinous pathway and grossly look very mucinous, but have a different morphology, different immunohistochemistry in many ways. They may be PAX8 positive, of course, but they usually will be CDX2 negative and variably with hormone receptors. These gross tumors can have areas that are difficult to differentiate. And on a purely gross standpoint, you may have difficulty identifying where the high-grade tumor is or where an invasive tumor is. And for that reason, it becomes very important to sample these so thoroughly that we can confidently exclude the presence of any other more serious type of lesion. Also, one of the things which we found helpful is to look at how the character of the mucin changes from one locule to the next, and particularly those locules that may look a little bit more pussy, a little more cloudy, to sample those, any solid areas to sample those. But generally, the rule of thumb is at least 1 section per centimeter of greatest dimension tumor. And usually you'll want to sample the surface, of course, to make sure that you've excluded surface involvement as well. Now, the last type of mucin-producing tumor in the ovary that needs to be mentioned is the so-called somatic type mucinous tumors that may derive from a teratoma. And in that circumstance, the mucinous tissue is germline-based tissue. It's not it's not ovarian parenchyma. It's derived from those germ cells, and therefore is going to display a more typical enteric phenotype without the possibility of there being metastasis. So if you have an enteric phenotype that's SATB2 positive, you have no primary tumor, that's one of the outs that you have, is to think that this may be a somatic type neoplasm. Still, of course, good to look and make sure, because metastases would be more frequent than this type of overgrowth tumor from a teratoma. Endometrioid tumors, of course, reflect the fact that these are tumors that look a lot like the endometrium. And this is characterized by a columnar epithelium with usually a fairly uniform, smooth surface, maybe a little bit frilly or something like that. And with the formation of glandular structures, occasional squamous differentiation, and occasional solid or cribriform areas. Now, clear cell changes or eosinophilic changes, as well as squamous differentiation, can be seen in these tumors. The immunophenotype for this tumor is usually Pax8 and CK7 positive, but also often Vimentin positive. In our laboratory, we use P16 as a helpful marker as well, because it will show a scattered, splotchy pattern of positivity. And almost uniformly, these tumors will be strongly hormone positive, ER and PR. Now, high-grade tumors may show some overlap with Cirrus type tumors and dedifferentiated tumors in some circumstances. So if you have a grade 3, more than 50% solid tumor, then you need to be more careful about some of the other markers and immunophenotypic alterations that you might see. To make things more interesting, occasionally sex cord stromal tumors like Sertoli-Leidig tumors can have areas that look endometrioid in this fashion. And we've also seen mucinous tumors that have an endometrioid-ish look. Now, of late in the literature, there have been recognition that many of the tumors that were previously termed endometrioid, that were termed pseudoendometrioid, or that were termed transitional. In other words, high-grade, often very solid tumors were in fact Cirrus tumors that resembled these other histologic types. And that's based on the finding of a fairly consistent TP53 mutational genotype in these tumors and high-grade tumors. So this term, the SET tumors, has come into the literature and may be used in some quarters, and so it's good to be familiar with that. Finally, seromucinous tumors. In some circumstances, people think of this as just areas where one locule is serous and one locule is mucinous. And that, while it may technically be true that you can get a mixture of like that, in the new WHO classification, this term more properly refers to tumors which have a variable type of epithelium all jumbled and mixed together. And it looks a lot like this in the sort of borderline category. Usually these tumors have round nuclei, and they have some cells with very cleared out cytoplasm that looks mucinous. They may have small mucin droplets. But in addition, they have other cells like these right here, which have nice terminal bars and potentially identifiable cilia. These tumors usually be Pax8 positive, and they may have variable P16 expression, might look somewhat endometrioid. Ciliated cells oftentimes will capture P16. But these tumors can also be strongly positive for mucin in areas. And this is a contrast here between a true mucinous neoplasm with an area of intraepithelial carcinoma, where you see this dominant exclusive mucinous type epithelium and so forth. And that is more characteristically a true mucinous carcinoma or mucinous tumor. Whereas the seromucinous tumors will have positive mucinal in the lumen along the surface in some areas, but also in some of the cytoplasmic vacuoles that you can see here on this mucicarmine stain. Whereas if this were stained with mucicarmine, it would be the entire cytoplasm here would be positive with mucin. Now, another tumor type that is not within the common epithelial tumor type, but which tumors which do occur in the GYN tract, perhaps with more frequency than many other places, are the so-called mesonephric type tumors. So mesonephric remnants or tumors that are derived from the mesonephric or Wolffian apparatus most commonly are seen in the lateral cervical and paracervical tissues and in the broad ligament, the tissues accompanying the fallopian tube, where we often find remnants of the Wolffian duct. Now, these tumors can also be deceptively positive for PAX8. That's not deceptively, it's not a false positivity, it's a true positive. But they're also usually negative for estrogen and progesterone receptor. They're negative for WT1, whereas they're positive with GATA3 and androgen receptor. So if you don't do these other stains and you get a PAX8 ERPR negative, well, these might masquerade as an endometrioid type tumor because of these large glandular spaces. You might even call it high grade because of more solid growth. But in fact, if you do additional markers, you should be able to differentiate this from the other tumors. But because this can mimic serous and endometrioid tumors, which are far more common, you do have to be on the lookout for aberrant staining patterns. These would usually be P53 wild type and not be marking like serous carcinomas. Now, we also use the term dedifferentiated in a number of circumstances, and we've done videos on this topic, these tumors before, both in the ovary and elsewhere. But in general, this is reflective of a high-grade tumor that we believe has evolved from or differentiated from a well-differentiated or low-grade tumor, particularly when we use this applied to the endometrioid category of tumors. Now, it is equivalent to saying the tumor is undifferentiated because undifferentiated carcinomas essentially are identical to these dedifferentiated tumors, with the sole exception being that dedifferentiated tumors have, at least focally, a well-differentiated component of lower grade. These tumors tend to lose markers, lose PAX8, lose hormone receptors, lose keratins, and therefore can be very challenging to even identify or differentiate as carcinoma in some circumstances. Heterologous elements, this term pops up in reports from time to time with a variety of tumor types. So most commonly, this is seen with, say, carcinosarcoma or with rhabdomyosarcoma, as in this image, but can also be seen with Sertoli-Leidig tumors and some other tumors as well. What it means is that there is some different type of mesenchymal tissue or epithelial tissue that is not recognizably part of the tumor differentiation itself. So cartilage tissue in a muscle tumor, that would be a heterologous element. Smooth muscle or cartilage or bone in a carcinosarcoma. Mucinous epithelium in a Sertoli-Leidig tumor. These are examples of this so-called heterologous elements in these tumors. As best we know, generally these do not have a significant prognostic implication, although that was once thought to be the case. Another term that pops up in the literature that gyn-onc should be familiar with is the term Pagetoid. And this illustration shows you what this is talking about. Pagetoid refers to a proliferation within an epithelial component, usually squamous, where you have the inherent tissue or epithelial type, squamous, with little nests or pockets of a different cell type. either a signet ring cell or a melanoma cell or an adenocarcinoma cell that is usually clustered together and migrating up through the squamous epithelium towards the surface. These occur most frequently with melanoma. This pattern of spread is also seen with, of course, Padgett's disease in breast cancers and extramammary breast Padgett's disease. It can be seen secondary to urothelial carcinomas that spread into squamous tumors, but we can also see it occasionally in breast ducts. We can see it in occasionally lung squamous tumors and elsewhere as well. It's named for Sir James Padgett, who was a surgeon and pathologist, one of the early surgical pathologists, truly. He trained and studied in London, and actually was one of the first ones to sponsor a journal club and describe it. He's had a number of notable discoveries, including those that diseases that bear his name, Padgett's disease of the nipple, Padgett's disease of bone, et cetera, et cetera. And right up there with Virchow, his lectures on surgical pathology begin to form the foundation for the development of this profession and this realm of knowledge. So a very important figure, albeit one who in this photograph looks a little bit stern. Well, let's move on to another term, coilocyte. What is a coilocyte? Well, this is derived from the Greek term koilos, which means hollow or concave. And these are coilocytes. They have this hollow center around the nucleus, this halo. And generally, this is indicative of a human papillomavirus infection because we see it in a number of these type of lesions. Not all that are HPV derived, but in some, particularly in the cervix and occasionally in the vulva and elsewhere. Generally, this is also associated with some nuclear abnormalities, such as a crinkling or wrinkling of the nuclear membrane, so-called raisonoid appearance, and this very sharp, quite firm margin of this halo. That's in contrast to so-called pseudocoilocytes, which have a less distinct perimeter and are actually due to just well-glycogenated cells. So the coilocyte and the pseudocoilocyte, sometimes called viral cytopathic effect as well, just because of the ease of understanding that term. Well, we use the term villi in many circumstances in pathology as well. It's a descriptive term anatomically for the small intestine where you have villous projections into the lumen. We use it in the placenta, such as here. These placental villi are variably surrounded by a cytotrophoblast and a fibrovascular core. But tumors can also be described as having a villous pattern. And those include endometrioid tumors, some cervical tumors. In these situations, this is really a purely descriptive term. And it doesn't necessarily have a specific phenotype per se or prognostic implication. It's purely an architectural pattern. Previously, it was separated out in the cervix as a distinctive type, felt to have a low risk of invasion and so forth. But now these tumors would be all grouped under the HPV-related classification in the WHO of 2019. So you can use the term as a descriptor, but it shouldn't generally be thought of as being a specific histologic or pathologic entity. Morial. What is a morial? Well, a morular refers to something that resembles a morula or a mulberry-like mass, a berry that has multiple seeds. So here's a morial. It's a berry-like structure, and it's got all these nuclei that look a little bit like seeds. And so that's where the term comes from. In embryologic development, the morial is a 16-cell stage of development, which is still quite solid as well, and might look a little bit like this. It's important from a pathologic standpoint because we use this term to describe a type of squamous metaplasia where you do not have much in the way of keratinization, but just this ball of fairly bland looking cells and associated with endometrial type glands, as you see here. Now, it can be a marker of hyperplasias. It can be present in polyps with some degree of atypia, such as a Mazur's polyp. These, in and of themselves, are probably not terribly significant, other than as a marker to say, hey, look closely at what else is here to make sure it's not something more serious. Now, in some more developed squamous tumors, these squamous morioles can actually develop areas of keratinization. As you see here, a little single cell keratinization, a little group of keratinized cells here. Here's a small grouping of these moriolar cells in within an otherwise malignant endometrioid type gland. And these are really not terribly important to comment on. We do subtype, endometrioid carcinomas with squamous differentiation and so forth to help us to recognize that they may be around, but usually that's not a critical distinguishing factor. However, in the case where we get keratin granulomata in the peritoneum, this does become an important thing to recognize. So occasionally these tumors that have that appearance in the endometrium or elsewhere will somehow dislodge or disgorge these keratinized areas, and these may float free into the peritoneum, lodge, and provoke a histiocytic response, which to the unwary might resemble a metastatic tumor site. But in fact, these are, CD163, CD68 positive histiocytes that are trying to digest and clean up this keratinaceous debris that has been dislodged into the peritoneal cavity. So that little gem is important to be aware of, both from a gross standpoint, when you're sampling these and sending them for frozen section, as well as when you see the primary site in the endometrium. Botryoid, another unusual adjective that is sometimes applied to tumors. This is a term that means having numerous rounded protuberances that resemble bunched grapes. Well, these don't look like the grapes that I buy at the market, but you can see that they're sort of gelatinous, thin-skinned, and very polypoid-ish, sort of like they're coming off a central stem. This is most frequently associated with rhabdomyosarcoma, or sarcoma botryoides, that occurs in infants and young children and primarily involves the cervix or vagina. Associated with this term is the so-called cambium layer. And so this is a phrase that's borrowed from botany, where the cambium is that germinative layer of cell growth just beneath the bark of a tree or a plant. So here the epithelial surface is likened to the bark, and the cambium layer is this very active germinative area just deep to that surface epithelium. Now, this is characteristic of several other tumors in addition to sarcoma botryoides or embryonal rhabdomyosarcoma, but it can also be seen in adenosarcoma, as well as in phylloides type tumors of the vulva or breast or other places. And so it's an important pattern to be aware of, this change in cellularity and sort of condensation of the proliferative activity and cellularity just deep to the epithelial surface. Cisterns, of course, this is an old term from the arid countries of the Middle East, frequently used as a likeness in the Bible, where the Lord says, my people have committed two evils. They have forsaken me, the fountain of living waters, and carved for themselves cisterns, broken cisterns that can hold no water. Well, in pathology, this term refers to a cavity that's a not epithelial lined cavity that's holding water. These are very fluid-filled spaces, usually occurring in the setting of a very edematous chorionic villus. And so typically these are associated with molar or partial molar pregnancies and have this very dilated appearance. Now, if we're only catching, or if we're catching these tumors at an early stage, before they become problematic, we may be able to detect them before you get many dilated cisterns in the villi. Just to review, a complete hydatidiform mole has dilated cisterns, has trophoblastic proliferation, cytologic atypia usually in that trophoblastic proliferation, and it has a paternally imprinted P57 pattern. In other words, negative for both the cytotrophoblast and the stromal cells. So that's the important and helpful distinction. In contrast, partial hydatidiform moles can be edematous and can occasionally form cisterns. They'll have some proliferation, but usually they'll also be able to identify more than one population of villi. So small, more mature ones, and then these dilated large ones. And there'll be trophoblastic proliferation, but these will be P57 positive because these are maternally imprinted. They have that maternal gene to express P57. Okay, we'll move on to Coll-Exner bodies. This is a term that came into the literature early and is considered a pathognomonic phrase for or feature of granulosa cell tumors. And these Coll-Exner bodies are these eosinophilic fluid-filled spaces that are generally small and surrounded by these fairly bland, low-grade cells with sort of coffee bean-shaped nuclei and central nuclear grooves. These are only found, however, in about 20% of cases. So if you find them, great, it's diagnostic. If you don't have them, yeah, you better keep looking, but you may be able to make that diagnosis on the nuclear features or other findings that you've got. Now, occasionally you can also see these in gonadoblastoma and rarely in endometrioid carcinoma, but those would be have other features that would be more typical of those entities beyond what you see here. Now, these were actually named for Emma Louise Coll, who's, I think, a very interesting and historical figure. She's one of the first female graduates in the United States, coming from the University of Michigan in 1873. As was often the pattern then, she went to Vienna to study, and she was a student under Sigmund Exner, who was actually a psychologist, psychiatrist, MD, and not particularly interested in pathology. But after a few years of study, she returned to the US in Boston, and it was actually her description from this time as a graduate student in Vienna that gave us this term of these, or not the term, but the description of these findings. So because she was studying under Dr. Exner, the body came to be called the Coll-Exner body. And of note, this was really, as far as we know, her only publication, but certainly a great and important one. Now, Coll-Exner bodies in some ways resemble rosettes, and we don't use the term rosettes very much in GYN pathology because this is largely a neuropathologic term, and the classification of different types of rosettes, the Homer-Wright rosettes, the Flexner-Wintersteiner rosettes, the perivascular pseudo-rosettes, and so forth, are important in that in terms of classification of a tumor and identification of the origin of that tumor. But we do use them in GYN oncology because it's the formation of ependymoma-like tumor tissue or neural tube structures that help to classify and qualify a teratoma as being an immature teratoma. So here we see such a lesion with a couple of rosettes and an immature neural tube type structure here in an otherwise mature teratoma. Well, this immediately makes it an immature teratoma. And we will grade these tumors, of course, based on the quantity of this kind of tissue that's present. And that's therefore important both for sampling and to be able to recognize this immature type teratoma, this immature type neural tissue in the teratoma. Samoa bodies, everyone has heard of samoa bodies, but what does it come from? Well, samos means sand in Greek. And if you're a Greek scholar, I'm sure you would recognize that right off. These are rounded, calcified bodies that are frequently seen in association with tumors, usually glandular tumors or small papillary tumors that have this capability or ability to essentially become calcified as they degenerate and regress. So we see it in papillary thyroid tumors, renal tumors with these features. We see it in ovarian papillary serous tumors, some endometrial serous tumors, though quite rarely. And then in the CNS, we can see it in meningiomas, pinealomas, and so forth. Rarely micropapillary lung cancers. In the duodenum, we see samoa bodies associated with somatostatinomas, prolactinomas, and some other tumors as well. So these are not a sine qua non feature, but they are something that can be found in a variety of settings, a variety of organ systems. When we're thinking about GYN oncology, I think it's very interesting to think about cytologic fluids. What does it mean when you see in a cytologic sample that has samoa bodies? Well, this very nice study from a couple of years back from MGH looked at this and evaluated, kind of what these might turn into be either on pathologic exam, because oftentimes they're just associated with a fairly bland type of epithelium that could be mesothelial, could be tubal, could be something else. But of course, we recognize them in malignant tumors as well. So in their study, they did a rather exhaustive evaluation of the follow-up of these women. And the most frequent outcome was that of a benign lesion, especially in adults. Most of them were, 53% were benign. Some sort of endosalpingiosis or hyperplasia or a benign tumor. Borderline tumors accounted for 14% of the cases. So that's a consideration. And then malignant tumors were accountable for the remaining 33%. So that gives you an idea. And of course, even in the malignant ones, many of them are low grade and a few high grades as well. Well, let's talk about one more feature, the Schiller-Duval body. This might be called the decorated donut, as one of my friends referred to it when we talked about it. Essentially, this refers to a nice mesothelial core with a surrounding decoration, necklace-like array of epithelial cells with a then space and a tumor or maybe flattened cells around the external area of that space. This has sometimes been called a glomeruloid-like or glomerulus-like structure because of the vascular change. In general today, we consider it pathognomonic for yolk sac tumor, although, as has been pointed out, it's only present in a minority of cases, maybe 20% of yolk sac tumor cases. Well, what's the history of this? Well, I'm turning to my colleague, good friend, Robin Young, who wrote a wonderful article in the International Journal of Gynecologic Pathology detailing the origin of this tumor and some of the people associated with it. So I'm citing heavily from that into telling the story. Dr. Schiller is a German-born pathologist who trained and began practicing in Vienna, but in 1937, he left Vienna and emigrated to the United States, where he worked for a while in New York and later became head pathologist at Cook County Hospital in Chicago. So after he arrived in Chicago, he described in this paper the mesonephroma ovarii, these structures, the so-called, in his term, glomeruloid bodies that he thought would be characteristic of this particular type of mesonephric-derived tumor. Now, we'll discuss a little bit more about the cases that he presented, but his work was followed on by Dr. Talem, who more clearly described and associated these bodies with a yolk sac tumor. Dr. Talem, I believe, was a Danish proposal, or Danish surgeon, but the other person of origin here is Dr. Duval, who was a German-born pathologist who moved to Paris after the Franco-Prussian War, during which he was, of course, an armory surgeon. And he described so-called intraplacental yolk sac extensions in some of these tumors that were present in sort of this germinative matrix. And that then led to his association with this neoplasm and this entity. Well, Dr. Talem kind of pulled this all together in classification and pointed out that these structures, which he called endodermal sinus tumor, now called the yolk sac tumor, had this characteristic feature of the glomeruloid type bodies that he described. And so his name goes along with this and drew special attention to this tumor and the ability to differentiate it from other types of tumor. Now, just to sort of make things interesting, the term actually the term Schiller-Duval bodies didn't actually appear until this paper in 1963, published by Dr. Huntington and his colleagues. And so this is when the eponym was born. Why they left out Dr. Talem is kind of another part of the story, but certainly Dr. Talem deserves a great deal of credit in this process as well. To then make things a little bit more interesting, Dr. Young points out in his article that his mentor and my mentor as well, Dr. Scully, had the opportunity to review Dr. Schiller's cases. He published 10 cases in that first Mesonephrum ovarii paper. And I'm looking at the slides. These are Dr. Scully's descriptions or his diagnosis based on looking at the slides from the retrospectoscope 40 years later. Case 1, 43-year-old, broad ligament, probably clear cell. Case 2, 8-year-old, probable primary vaginal endodermal sinus tumor. 20-year-old female, probable endodermal sinus tumor. 13-year-old, endodermal sinus tumor. 69-year-old, clear cell carcinoma. 52-year-old, clear cell carcinoma. 40-year-old, probable clear cell. So you see there's a distinction here. Many of them are probably clear cell carcinoma, particularly if they're in this older adult category. And one, of course, you see here, he couldn't tell what it was. So I thought that was very significant, but it points up the value of being kind as we look back retrospectively, as well as the important feature of understanding the age and demographic of the patient that we're looking at. Easily, if we're looking at something with a pediatric age group in mind, we're thinking of a different set of scenarios than if we're looking at a tumor from a 69-year-old. And so therefore, it's very important to communicate that both between surgeon and pathologist as we consider these lesions. Well, let me close off with just a brief word about Brenner tumor. It's one of the few remaining eponymous tumors that this is composed of nests of transitional epithelium amid a very dense fibrotic stroma. Now, this is often just a benign finding or even an incidental finding, but there are borderline and malignant tumors that have this growth pattern. So here's what that growth pattern is. You see a very fibrotic background, cellular stroma, and then you see these solid nests of transitional epithelium, which may occasionally become sort of cystic or glandular-like or have little small bacular spaces associated with them. These are probably related to the Walthard rests that are seen commonly along the surface of the ovarian tumor, or through the surface of the fallopian tubes or broad ligament, as those also tend to have this transitional type of epithelium. Well, Dr. Brenner, again, a sort of 19th century physician who lived early into the 20th century, physician and pathologist, he described this tumor in 1907. And it wasn't until much later that Robert Mayer in 1947 1950s, named this term the Brenner tumor, tumor. And Dr. Brenner didn't even discover that it had been attributed with this term until the 1950s. So I think that was kind of interesting. Just go about your work and don't care. It doesn't matter if you get the credit or if it gets named after you, just do a good job. And maybe fame and glory will come at some point down the road. Well, that's kind of the end of this. I welcome your questions. You can make comments in the video below or contact me via the contact information in the description. I hope you enjoyed that. If you'd like to see more on these kind of sort of overview survey topics, please let me know. I will look forward to hearing from you and appreciate your interest in our channel. If you like this and have friends you want to share it with, please do that. That helps us to get to more people. So until next time, thanks so much for joining.